Welcome to Blue Talks.
Thank you so much for having me today, Northwestern University. If you spoke to a graduating medical student and you asked them, what is the most important class you took? They'll probably say something like pathology, pathophysiology, histology. Basically, none of them are going to say biochem. It's a running joke with us. But those are typically the answers that you'll get. My name is Dr. Monique Nugent, and I graduated from medical school, let's just say, a few years ago. And if you had asked me the same question when I graduated, before I went on to become training in internal medicine and to become a practicing hospitalist, I'd likely give you the same exact answers. But now, reflecting 15 some years later on what was actually the most important class I took in medical school, my mind goes to a class way in the first year, in just one semester, called Understanding Your Patient. And in that class, we were meant to learn more about how people think and how we were to connect with patients. That, now I understand, was actually one of the most valuable classes of medical school. But when we think about medical school, those med students aren't wrong, right? When we talk about what makes a competent physician, we want them to be able to recall the physiology and the pharmacology of what they've learned. We test physicians over and over through years of medical school, in-house tests in residency, STEPS tests, and then eventually your board exam to say what makes a competent physician. And we've settled on facts, things that we know they'll learn to improve a patient's care and safety. Now, don't get me wrong. I don't think anybody's going to argue that those things are not important when it comes to training a physician. You want your physician to know the newest, the latest, the greatest. We want our physicians to make sure that they're creating safe care plans for us. But is that the only thing that makes a competent physician? I think back now, being a hospitalist, seeing acutely ill patients and their family members, back to that Understanding Your Patient class. And the real value of being able to learn to walk into a room on what is likely to be somebody's worst day, make a connection, build a therapeutic bond, carry that bond through your hospital stay, build trust and rapport with you and your family members to not only create a care plan that addresses your medical needs, but takes into consideration your social needs, your values, your goals, your spiritual needs and understandings, and your ability to care for yourself and your loved one in the community. Years later, that's what I've come to understand is a big part of what makes a physician competent. When I was a resident, my residency was pretty heavy, we would say, on hospital-based care. Probably no surprise that I went into hospital medicine. But I remember this meeting, sitting with a family in the ICU, surrounded by really brilliant minds, attendings who taught me the ins and outs of ventilators, how to diagnose and treat severe illness. And we sat with a family, and I watched these really brilliant minds give very beautiful and concise descriptions of what was going on. In their most compassionate and understanding way they could, they explained things and were starting to demand answers. And we hit a wall. This patient's husband just couldn't get past what we were saying. and I watched these really brilliant minds who could read an EKG not read the room. They couldn't get what was actually happening. At the end of what was a really difficult meeting for both us and the family, the husband looked at me and said, "Can you at least tell me one good thing?" That has stuck with me for years. That in everything that goes on, in illness and injury in the hospital, not being able to read the room, we missed that he needed just one good thing. So what do we actually need to do to teach physicians, medical students, to be competent communicators? My suggestion is that we teach communication with the same rigor that we teach the sciences, and go back and do testing and retesting, understanding that some students may not grasp the topic as well as others, that the same things that may make a person a really great surgeon, attention to detail, the ability to focus and only see the small thing, might also be the same thing that makes it hard for them to connect, read the room, and continue building and maintaining a therapeutic relationship. Helping to meet those students where they are, helping them to remediate, shadowing people who do it well. Each one teach one, right? And going back to the same topics over and over. I have created a communication curriculum for residents or physicians over 3 years, focusing on ethical communication, focusing on whole person communication, and focusing on revisiting those topics and building on your strengths. We should not expect a first-year intern to have the same level of communication and empathy skills as we should expect a third-year resident. As somebody who has sat and gone through patient complaints, there are a fair number of times that a patient and their family will complain about the specific medical care. But let me tell you, the overarching numbers of complaints are based around communication and lack of connection. This physician was so rude. He just looked me in the eyes and told me the worst thing I've ever heard. This doctor keeps trying to shove this thing down my throat. She doesn't understand that I'm scared of it. But these are outcomes that are expected. When you focus on teaching the facts, the figures, the therapies, and don't focus and realize that the other half is important too, you're going to have the same exact outcomes. So, my solution, like I said, is to teach these skills with the same intensity. Go back and get the evidence-based medicine that we use for the clinical skills and put them over into the communication skills. We've done the research. We know what works. We have the feedback. We know when a doctor's touch is comforting and when a doctor's touch can be traumatic, and the difference between the two. We need to focus on teaching our residents and our med students how to connect and revisit those skills over and over. Thank you so much for your time. And again, thank you so much, Northwestern University.